I'm so excited because my friend and my colleague, Dr. Sherry, is joining us today for an Ask Me Anything. This is a long time, probably years in the making, that she and I finally get to do something like this together. This is so exciting. Happy to see you.
I'm so glad to be here.
This is great. So I want everybody to know a couple things first about the fabulous Sherry. She has an OBGYN practice at St. John's in Santa Monica. She's delivered a lot of celebrity babies. Okay, lots of them. She has this amazing book out.
Are the same. All vaginas.
I don't believe that. I think that's like saying all penises are the same, and they're just not.
Good point. Good point there, Alice.
So Sherry and I have a lot of fun together. We've gotten to do projects in the past. She's an inventor. She's always thinking, what is the best thing for the patient? And what can she do to kind of improve patient experience? And that includes coming up with a line of holistic, whole food fertility vitamins, not just around fertility, but also menopause. So she is going to join us every other week on Fertility Tip Tuesday. And we're so excited and lucky to have you.
I'm so excited to be here. I really am, Alice. I love your energy. I love your creativity. I love your passion for educating women and being their best sort of healthcare advisor. And you're just amazing. And I'm so glad to be here, and I'm grateful.
That's awesome. I love you. Okay, we are going to get to some questions, and I'm going to ask some questions too. So when folks don't ask, there are always things that come up in the Fertility Answers app that we know people need answered. All right, we had a PCOS related question. Here, let me scrolling. Hi, everybody. It's so good to see you all. All right. Myo-inositol. So I think first I want to back up for a second about the line between kind of OBGYN and reproductive endocrinologist. So you see people with PCOS probably all the time.
I do. I actually do.
And then what do you do to kind of diagnose and treat? And then at what point do you need to hand off to an REI for extra help for conception?
Yeah. Well, as you know, PCOS is, they're not ovulating, right? Not every month you're ovulating. And if you don't ovulate, you can't get pregnant. So it's all about first meeting with the patient and really understanding what her goal is. If you're coming in and you want to get pregnant now, we talk about your ovulation history. It's so important. I love period trackers. I think everyone who has a uterus and who has a period should be using them, because it really is such a great piece of information for the OBGYN, especially women who are trying to get pregnant. So you come in with it, it gives us a lot of information about when you're ovulating. And, and that's the whole problem with ovulation and pregnancy in PCOS patients. So it can be as easy as, putting you on something like Clomid. Does that help you ovulate? If that does, we can sort of go from there. If you're not ovulating but twice a year, it might be a bigger problem. And then, of course, your age. So it's age and ovulation, and it's the conversation.
One of the things that I love about you and how you approach your practice, which is kind of what you did in your book too, is you give patients so much of your time. And in a lot of cases, there are health systems where OBGYNs get like 7 minutes with their patients.
That's right.
How have you been able to maintain kind of the integrity of your practice where you give your patients a lot of your time?
Well, I'll tell you something. You're right. The average time a doctor spends with their patient is 7.5 minutes. That's ridiculous. We have a broken healthcare system. And, when it comes to fertility patients, you all are very smart. You've done your homework. You come in with your list of questions. And I love it, because that tells me that, you're in it. You are committed and you want to have this happen as quickly as you can. So, often you have to schedule a consult with your gynecologist, your OBGYN, just to have a conversation.
Love that.
That's what I would do.
We have advocated for that too, where we say, try not to have it at your annual, because there's certain boxes you have to check. And we want to make sure that we're not trying to collapse too many conversations into one space of time.
That's right.
Yeah. So we love for you guys to do that. Schedule a separate conversation with your OBGYN just specifically to cover all your fertility kind of boxes.
Yeah. So it's really about talking about issues that we don't typically talk about, normalizing them, bringing out the embarrassing topics,
Yeah.
the taboos, talking about our vagina, talking about taking care of it.
Just saying the word vagina.
Just saying the word. And then, of course, when I wrote the sequel, it was a continuation, because you just cannot write one book about the vagina.
Right.
Just no way.
Right. One of the things that you guys listening can ask about, you can ask about things like vaginal steams and douches and things that, you wonder should they be regular things in your repertoire? This is the chance to ask Dr. Sherry those types of questions. Mitzi is asking, Mitzi has the cutest handle because her handle is Mitzi. Oh. Very cute. I love it. She's wondering if you've treated someone with fibroids and adenomyosis and early in pregnancy and kind of throughout pregnancy. Like how do fibroids and adenomyosis, I said that correctly, right?
Adenomyosis. It's a tough word to say.
It's a tough word.
It's very tough.
Serena's always telling me how to say it, and yet I don't get it right every time.
Well, don't feel bad. Well, Mitzi, this is a really good question, because, fibroids are really common. I mean, up to 50% and maybe even more women have them.
Wow.
And probably, as you know, a lot depends on where they are located. Where are those fibroids? If it's in the wall of the uterus, if it's in the cavity of the uterus, that could be a real problem as it relates to fertility. So the size and location really matters. And, most fibroids we don't have to do much about. But the truth is, we're seeing women getting pregnant older. So those fibroids who, in their 30s are going to be a lot different in your early 40s. And sometimes if they're in a bad location or causing irregular bleeding, we have to take them out. And sometimes that number, like how big is that fibroid? It could be the size of some would maybe say the size of a grapefruit.
Wow.
8 centimeters or bigger, regardless of where it's located, because in pregnancies, a lot of time those fibroids, they can double in size.
Wow.
And they can compete for blood flow with that growing baby. So, it's a bigger conversation. So a lot, again, is your size. Getting an ultrasound will determine that. Your symptoms, how it's affecting your periods, and the location. Is it going to compete for space inside that uterus? And so that's with fibroids. And you can have them removed with a myomectomy, and then have a successful pregnancy. And a lot of the infertility doctors always are concerned about that cavity. What is the shape of the condo? How is it doing? What does it look like? And a lot of times fibroids are a lot easier to treat and manage than adenomyosis.
So let's talk about adenomyosis, because we have a second user who wants to talk about that too. What's your recommendation when that is the issue? And this user, Melige Riley, has had many failed IVF attempts, and it's sort of said that it's her adenomyosis. Am I saying it right now?
Yeah, adenomyosis.
Adenomyosis.
I had to go to med school just to learn how to say that word.
I need the phonetic spelling. I think that's my issue. I need the phonetic spelling like right next to my phone.
Like a lot of the words, medical terminology. Yes. I think it's just meant to confuse us.
Yes.
So adenomyosis is really endometriosis, very similar.
As
far as we find glands inside the uterine cavity, but now they're in the muscle, they're in the wall of the uterus where they shouldn't be. So every cycle, every period, those little glands that are in the wall that you can sometimes see on ultrasound, you can definitely see on MRI. You can see them in there because it creates a really plump muscular wall of the uterus, but it's not so great for getting pregnant. And they don't always know the why. Is it harder for these women to get pregnant to why do they have maybe more common miscarriage rate. And it's a challenging one. It is really a challenging one. And it's a good conversation to have with your infertility doctor. But, I don't know, what you're telling or what the latest is, but if you've had one and certainly two miscarriages, that's the time to find an infertility specialist.
Right. Well, and you're talking about something that's an inflammatory condition, right? And in some cases, if you try to remove it, you might be left with scar tissue. And so
yeah, it's hard to remove adenomyosis.
Wow.
You can't really remove it. I mean, the treatment is a hysterectomy.
Wow. That's a tough pill to swallow.
That really is. So that's not good.
No. Yeah. And same thing with fibroids, right? Like eventually some people choose to do a hysterectomy to eliminate the fibroid problem completely. People who are super heavy bleeders and have tried everything else. And that might be the best.
Yeah, that is definitely the last stitch effort. This is a hysterectomy, but certainly in the women who are trying to preserve their fertility, we're really mindful of, preserving that uterus, and we have to really know, are those fibroids going to be in the way?
Right. Got it. Now, you probably also see a lot of patients that look great on paper, like their labs check out. Some of them might have even had a previous pregnancy, and they fall into that phrase that we hate, which is unexplained infertility. Because we hate that because it's like there's got to be a reason,
Yeah.
So
Yeah,
what do you usually recommend at that point when it looks like unexplained infertility to you? Do you usually refer them out to an REI, or do you maybe try an IUI first before they move on to more invasive, diagnostic workup?
Yeah, I mean, and again, this is not necessarily what the average OBGYN is going to sort of involve themselves, because, as you know, unexplained infertility is almost the worst because you don't really know what to do about it.
Exactly.
But also, I believe in faith and prayer sometimes. And sometimes, you're also of the category that you get pregnant on a spontaneous cycle. But usually unexplained infertility patients, they've really, done their due diligence. They've seen their infertility doctor, and that's sort of the team. I really like the team approach. Infertility, myself and my good old, acupuncturist and nutritionist, because it's really sometimes what you need to do, but unexplained infertility can be definitely challenging.
Yeah, it's one of those many terms that we need to rename.
Yeah, definitely.
All right, this is a good question, my happy place. Not really a question for Sherry, but I'm going to bring it up anyway, which is just about genetically tested embryos. Should we save that maybe for Dr. Chen next week? What's
the question?
Well, the question is, do they each have a fair shot of implanting if they've been genetically testing? So I feel.
Yeah, I mean that they always say that, I mean, overall that and I think it just depends too on your age and if you need to get that genetic testing, but it seems like we've been doing a lot of genetic testing on those embryos, but I actually be curious as well to see what that answer is, if there's something new that I don't know about.
Yeah, and that's a great question to ask on the app too, if you don't want to wait till next Monday with Serena. My happy place is just, that's a perfect question even to ask my business partner. He's the one that invented genetic testing of embryos. So he will have an accurate answer for you. I'll make sure he does answer. All right, Jessica, that's cute how she wrote her handle. What can she do if the ovulation strips come out negative while taking Clomid?
And that happens. So it depends. I mean, usually what I would have my patients do, regardless, is have them come in for an ultrasound. And again, your cycle, when you think you should be ovulating. Sometimes we'll start on day 10 or day 11 of your cycle to come in to start to watch the follicles grow.
Got it.
Watch to see what they're doing. And that's, again, knowing your cycle and knowing you don't want to go too late and you don't want to go too early. And it could be, once you sort of hone in on that ovulation window, especially with Clomid, you're going to want to do it daily, probably day 11 or day 10 on.
All right, that's really helpful. And if somebody has PCOS and they're taking Clomid, we try to steer them clear of just LH tests anyway, and encourage them to rely on their doctor with ultrasound scans or progesterone, so that they don't get confused by the result. You know, because we see in PCOS patients their LH kind of being all over the place all month.
Yeah.
Oh, Dante has a question, but it's just, when will we be done? 20 minutes.
Oh, Dante.
Dante often pops in and says hello to everybody.
Hi, Dante.
Dante, Sherry has a uterus plush for you. It's a uterus plushie. When you're a single mom, everybody, you like your young boy is raised knowing what a uterus is, knowing what a period is, knowing what tampons are, and everything else. So we advocate for real words, right?
Absolutely.
Always.
I think that's, you know, the pendulum is swinging of how we are educating our young girls and boys on their body parts and using the right words, not using code names for your vagina.
Right. And you had sons. So was it different, you know, you being a physician in women's reproductive health? I mean, were you already having those frank conversations with them when they were young? What would they say now?
Yeah, I mean, vagina rolls off their tongues very easily. I mean, they get it.
Yeah.
I mean, often they're a little mortified by me, but they're helpful. And
well, wouldn't we be failing as parents if they weren't mortified of us a little bit?
I like to think it will just make them good men and more kinder, gentler, good listeners. But yeah, it's good. I mean, you know, I think they get a little embarrassed when I ask if I can check their girlfriends for STDs before they sleep with them.
Oh, that's fantastic.
That's
That's a joke. C. Caroline Forest Lawn is asking, is there a certain age you truly would advise against carrying a pregnancy?
Well, you know, it's changed so much. I had a 52-year-old that I delivered her twins through. She had a donor egg. Wow. The answer really is going to be based on your health. Mm-hmm. I mean, you know, as you get closer to 50, your vasculature, right? Your veins and your arteries, they're just not as strong and healthy. So we always worry about some of the consequences. An older woman over 50, you know, even anyone over really 45, as far as high blood pressure, diabetes, increased risk of C-section, fetal distress, and there's other, you know, health concerns for the mom. So it's that conversation that you're going to have about your overall health and wellness. And, you know, surrogates it's such a great option. I mean, I love surrogacy. We're seeing it more and more too.
I just read an article about a single dad who, you know, used a surrogate to become a parent. Yeah. And you're even seeing that more and more. Yeah. Single dads by choice, not just, you know, single moms by choice, which is cool. It is expensive, but we do have lots of different options for people if they are considering that. And even though the borders have been closed this last year and there's been some complications, we love some of our partners in Europe, in particular in Ukraine, who have great surrogacy programs, and it at a much more affordable cost. So even some of the cancer survivors that I've helped along the way, you know, exactly. Wow. I actually have one now. She has leftover embryos that she wants to donate to somebody else.
Wow.
Which comes up a lot too. I know.
You know, and that's a really great thing I wanted to mention, because embryo donors, I think are so interesting. And I don't know what kind of conversation we've been talking about, you know, but I think it's a great option. Yeah. About this whole donor embryo. So what is Nikki Brown asking? I want to answer your question.
Yes, Nikki took an ovulation strip Saturday when I saw egg white mucus when she went to the bathroom, but the test strip says low. So is it just saying low LH? I guess what kind of test strip is it?
I mean, all that, I always warn my patients. I said, when you see that egg white discharge, that slippery stuff, that is almost your best test. I don't know what you're dipping in or peeing in, but when you see that, that is like an infertility doctor's dream,
Yeah.
especially, you know, and it's such a great time to have sex because it really does help the sperm find its way into the uterus.
Yes. So like if you have that, don't worry about the test strip. Just go have sex.
Exactly, exactly. And I think too, it's like if you are confused, because you know these
Yes.
over-the-counter test strips, they're not 100%.
Right.
You know, and if everything's looking good and your period tracker's been telling you
Right.
this is the time, this is the sweet spot to have sex, and you see the egg white discharge, you know, that's all you need. But always ask your fertility doctor. You can always go in for an ultrasound.
Yeah.
That's going to be helpful.
To get confirmation that you're either about to ovulate or you did ovulate. Right. To be more specific.
Exactly. I mean, it's not always practical,
Right.
but if it's possible, that's what
Exactly.
I would do.
And when it's not practical, we do recommend the uva.life ovulation confirmation kit because it does measure both LH and progesterone. So, you know, we do like that for folks who really do want their own data and they don't have an opportunity to go in to get the ultrasound to have that confirmation, is that their kit it's just amazing. And I actually have one. It's somewhere in my office. I'm going to start using it. And not because I get to
For
have
yourself?
Yeah, not because I get to have sex and have a baby. That's not happening, you know, in my situation, you know, post iatrogenic infertility from cancer, but mostly because I'm 44 and I'm trying to squeeze in an embryo transfer this year after I get the vaccine for COVID. And I just kind of want to know what my body is doing.
Yeah.
So I just want the data.
Yeah,
you know, I'm like all about the Apple Watch and all my data tracking.
Yeah.
So let's see, D. Reilly's or Dr. Ely's, one or the other. Okay, so what do you recommend for someone who doesn't regularly ovulate? She had growth hormone deficiency when she was younger, but all her tests are showing up normal now, but she's still having trouble getting regular periods and ovulating on her own.
Well, I mean, you know, that might just be you're in that challenging category of just not ovulating regularly. And I don't know if you have tried the injectable hormones or not too, because, you know, by then you have bypassed Clomid and then it's time for the big guns. It's time
Right.
to, you know, before you have to go to a donor egg situation, you know, you want to use the injectables and really find out from your infertility doctor and maybe meet with 2 different infertility doctors. I'm all for that.
Right.
Because there's a lot of different ways to do things and different dosing and so on. But that's what I would suggest.
That's really good advice. Then one thing I would add to that is sometimes you need to try things to see how your body is going to respond because it gives you more data. It gives you more knowledge about like, look, what is going on here? Is a quote unquote easy fix with like Clomid and letrozole or something to get you ovulating. And if it's not, and then you have to move on to something stronger like the injectables, how do your ovaries respond to the injectables? That's all information that a specialist would need to be able to advise what's next. Okay, Snafe, I don't know this handle, but this sounds terrible. She's been bleeding heavily for 2 months now. How do you get people to stop bleeding?
You know, first I would want to know her age and what her overall history is. But, you know, the first thing we like to do is always, you know, do a pelvic exam and then do an ultrasound to make sure that there isn't any organic findings, no pathology, no fibroids, no uterine polyps, you know, or no ovarian cysts that sometimes can cause it. And then, of course, we want to do blood work. We want to make sure you don't have a thyroid disorder that often can come up with, you know, first sign can be irregular periods. So we check blood work, we do a pelvic exam, we look for other organic causes, and if those are all negative, there's different hormonal. I mean, this is saying there's a hormonal imbalance, right? If you rule out all the organic causes. So sometimes you need to do a reset. It could be going on the pill for 3 months. It could be going on cyclic progesterone for 3 to 6 months. It could be putting in an IUD. And then, of course, do you want, you know, to get pregnant or not? So it sort of depends on where you are.
That's great. I love that answer. So you have options. That's also good, right? You have some things that you can talk to your provider about. But the prolonged risk of bleeding for 2 months straight, are we concerned about anemia? Are we concerned about any other deficiencies?
Well, yeah, and also in that blood work, we're looking at a CBC, looking at your H and H, make sure you're not anemic, and we're doing your pregnancy test, right? That would
Right.
we want to rule that out.
Yeah.
Um,
Right.
So it depends on how much, like everyone's perception of how much they're bleeding. That's a an interesting study in and of itself, because you can spot, or you can clot, or you can just have this little trickle. So it depends on that as well. And we can really tell that, quantify it by getting an H&H and looking at your hematocrit and hemoglobin.
Okay, super helpful. Love that. Sav Crawford, is it true that people who do IUI have a higher chance at having a boy?
Well, the answer is I haven't heard that. We some people do gender selection where they spin the sperm, and they literally separate out the boys and the girls, because girl sperm or boys sperm swim faster to the egg. So if you have sex closer to ovulation, the boys sperm are hauling it to the egg, right? But they die sooner, and then the girl sperm are in the back, because we're so smart. We just take it slow and steady and low stress. And so we're slower just, to get to the egg, and we live a little longer. So I don't know if that question comes from, was there a sperm separation for gender or not? But in and of itself, the answer is no.
Okay, that also brings up kind of an important point, which is, and relates to another Nikki Brown kind of part 2 of her question, which is that sperm can live for up to 5 days.
That's right.
So that it's better to be a day or two early when you ovulate rather than 2 days late, because you get, what's the window for when you ovulate? When the egg is floating around.
It's 24 hours, but the question is, and I think, Nikki, it's a good question, is, you see the egg white discharge. So that doesn't mean you're ovulating yet. It means you're going to probably ovulate in, 24 to 48 hours, or maybe even 36 hours, right? But because the sperm lives up to 5 days, that's the moment to have sex.
Yeah, great.
And to your point, Alice, I mean, you want to have sex on day 11, knowing you're gonna ovulate on day 13 or 14. There'll be sperm there. There'll be girl sperm there, but there'll be girl sperm.
Exactly. So Nikki she did perfect timing. She had the egg white discharge on Saturday. She had sex on Sunday. Perfect.
Yes, that's right.
Might be boy sperm, but that's a little mythology. Okay, so
50.
Yeah. So Melly J. Riley, I think we just, Sherry answered this question. So when the egg white discharge is there, you have not missed your chance. It's just go time. So yes, that's just clarifying that, it's go time.
That's right.
Okay. Our sister, simple question. What is the average wait time to get pregnant?
After a miscarriage?
I think just in general. So
wait time to try on your own, you mean, maybe?
Yeah, maybe that, and like what the percentages are.
Yeah. So, used to be you wait 1 year trying on your own, and then you go see your infertility doctor. I mean, I think it's changed a little bit. I think it depends on your age. If you're over 35, you're going to want to try on your own for 6 months, and then you're going to go to infertility doctor. So, I'm all for, if you and your partner want to try to get pregnant. I mean, problem is 50% of us have unplanned pregnancies. So you haven't gone to your gynecologist to do sort of the preconceptional checklist, but it's good if you can. Because then you're really honing in on, when you're ovulating, and it's all about statistics and honing in on, timed intercourse. But a year for anyone under, 35, if you're healthy, that's when you'd go see an infertility doctor.
Yeah, absolutely. And you have to remember that even a healthy 25-year-old, there's only a 25% chance of getting pregnant every month that they try. We get 1 egg.
That's it.
That's it. So, what Serena always says is, like, over the course of the year, there's still 85% of people that can be successful over the course of that year and 15% who won't. And what we want to encourage is don't stress about it. You know, that if you're worried, get into it to your doctor or a specialist right away, because your worry is going to it's going to remove all the romance out of it.
That's true. Yes.
So, yeah. All right. Sarah Walker just wrote in with, she had a miscarriage in October. First of all, we're so sorry, Sarah. We have so many people in our community with losses. I had 5 myself. She did turn 40 in January. So, you know, what would the path look like for her, Sherry?
Yeah. So, you know, over 40, you're on getting close to that fertility edge of the cliff, and you really want to be very aggressive about, you know, making a plan. I always say it's 40, you're right there. You need to make a short-term plan, plan A, plan B. Plan A could be 3 months of, you know, IUIs. And then thereafter, you may have to go to infertility doctor to do, you know, more high-powered injectable hormones to ovulate. You know, just have a game plan. At 40, it's the go time. So that's what I would say.
That's great advice. Sarah, if you have follow-up questions, feel free to ask them. But I do love that it's, you know, we kind of echo the same thing in the Fertility Answers app. And if we need to get you to a fertility specialist because you want to go the aggressive route so you can get as many eggs out as you can, we can find you a provider. We have free fertility advocates who can help with that, Sarah. So feel free to connect with us either through direct messages or on the Fertility Answers app. Frenchie Jen is asking such a great question. Same-sex couples that are doing IUI, is it the same timeline before they would go the IVF route?
Well, you know, that's a really good question, because in some ways, same-sex couples, you know, you go, you know, can't do it at home. Although I've shown many of my lesbian couples how to do their own inseminations, because I'm all for that at home. But
yeah,
you know, if you're using a doctor and you're doing your IUIs, I still think it's good to have a time frame. At least it's a little more efficient planning, where you're doing 3 to 4 to maybe 6 IUIs, and then you go to the infertility doctor. I mean, the problem always is it's expensive.
Right.
It's so expensive. So
yeah,
on some level, same-sex couples have to be a little bit more knowledgeable, because it's so cost prohibitive. And sometimes you're like, you know, we're just going to do 3 or 4 IUIs. If it fails, we may just go to IVF.
Yeah.
And there's no wrong answer. You know, I think it depends on the ages and your financial situation.
Yeah, I absolutely agree with that. I think that so much of the planning, you have to take consideration the finances and that window of time, you know, and how much kind of stress and it not working can the couple endure. I always like to think about it like that, where, you know, do you have 12 IUI cycles in you? Do you have 12 IUI cycles in you that failed plus 3 IVFs? Right? Because the longer you wait to even go to IVF, then the more cycles you might need. So I think that people have to think through the emotional weight and what can they endure? Because it's such you know, when you need assisted reproduction, it's an endurance.
Yeah. And, you know, and I think that's a good point. And seeing a therapist is so helpful.
So helpful.
Because it's just very, very hard, you know, and stressful. So it's always about, you know, I mean, age, no matter what your, you know, sexual preferences, age has to be first and foremost. Just make your plan of action. And then it's, you know, knowing your, you know, ovulation history and just then knowing sort of what your bandwidth is to seek infertility care. But it's always good to use your doctors and use ones that you like and that are really listening to you.
Yeah, I love that. So Sarah started seeing Dr. Stalling. That's great. Okay. She just, Frenchie Jen said she was confused into why they allow opposite sex to try for a year, but we're told after 4 failed IUI to do IVF. It's probably, I mean, IUI is more efficient of a process than sex. I mean, you're getting the sperm closer to its target, right?
Yeah, I mean, it's actually a very interesting question. I don't think it's necessarily like you couldn't wait. Like if money and just the way it all goes down with same-sex couples with IUIs. I mean, I have many who will try for a year,
Sure.
picking up the sperm, using the long, Tom
Mm-hmm.
catheter and just inserting it into the back of the vagina and doing like
Mm-hmm.
an ICI, right?
Right.
Intracervical in the vagina. So it's not that you don't necessarily have to, but there is a sense of, all these factors that we've been talking about that you have to take into consideration.
Right. Yes, exactly. And that might be, if you got that recommendation, it might be your IVF doctor just based on their own data. If you're doing IUIs through an IVF clinic, they might have their own data that says we see more success. Like if somebody's going to be successful, they might see 80% of the time they were successful within the first 4 IUI attempts. So check in with wherever you're being counseled on your IUIs, because it just might be the own clinic's data that's saying we're going to do 4 and then we want you to move on. It could also be insurance. So there are some states that do cover IUI and IVF for same-sex couples, and sometimes they have parameters on when they will cover IVF. And Maryland, I believe, removed their law for this, but they used to require 6 IUIs before they would be willing to cover IVF. And in some cases, that's not clinically a good recommendation, based on your age. I mean, if you're 40 and they're willing to cover IVF, you wouldn't want to waste your time with 6 IUIs. Right. So yeah, I think that maybe just give us some context about who's giving you that advice to only try 4. Because I don't know that it's published data. It just might be unique to her clinic.
Yeah.
All right. So a question kind of along that front is, when a man gives sperm in a cup and it's an at-home insemination, do they put it in the refrigerator or is it room temperature? And what's the window that they need to use it?
Wow. Well, good question.
I know, very specific.
Yeah, I don't think I don't know if, I mean, I think sperm like warm place. I would definitely defer to Dr. Chen for like the at
Actually, we could,
home.
and also Dr. Spitz. So Dr. Spitz, who's like your male counterpart, he wrote the penis book.
Oh, he did.
Yeah. So you guys,
Okay.
and you guys are both in Southern California. So he'd be a great person for us to ask to, Dr. Spitz.
His name's Dr. Spitz, really?
Yes, it is
Wow.
really. And he's
That's like
urologist.
Dr. Bonnie Beaver, who's a gynecologist.
Exactly. But I will say, for my sperm banking days, sperm is pretty hardy samples, but it does start the degradation process quickly. So I would just advocate, even without getting the answer from Dr. Spitz, but he is doing a show here soon with me. So save that question or DM it to us and I can get it to him, is try to utilize the sample within an hour of collecting it. That's typically what we would see. Yeah. So if it's at home, I would try to use it right away.
And I know when the sperm is brought to us after being washed at a sperm bank, they like it to be inseminated within 2 hours. And that's at room temperature. So,
exactly.
Unless it's frozen or it's in the defrost.
Exactly. The refrigerator is not going to do much.
Yeah, it may even kill the sperm.
Yeah, exactly. Okay, so some other really good questions coming in. So Annette got pregnant from her first PGS, so genetically tested frozen embryo transfer. Is it still possible for her future transfers where she might still experience recurrent pregnancy loss?
Well, I don't know the answer. I mean, if it's a healthy embryo, I guess it depends what the losses were as a result. Was it embryo related genetics, or does it have to do with anything within the cavity, or like an adenomyosis case? So I think it just depends on that. So I don't know if she's going to be still at risk, just because I don't know enough about your background.
Yeah, gotcha. That might be also a good question to ask on the Fertility Answers app, because you do fill out a health profile for us. And so it would give our board certified experts a little bit more information to help answer that question for you. You might have a reduced risk, but not no risk. So PGT embryos don't bear no risk for miscarriage, even if someone doesn't have a history of recurrent pregnancy loss. So that's just something to consider, that it reduces our risk, but never can make it zero, because there's just so many magical factors that go into producing the healthy outcome that we're going for. I mean, it's hard to wrap our head around, Sherry, that 50% of pregnancies are unplanned, because those of us who are trying to plan, it's just, you feel like you look around and everybody's pregnant except you.
Yeah, no, it's true. It's very true.
So Lauren, who's almost 12 weeks, which is just awesome. Lauren's been in our community for a long time. She did blood work at the 10 weeks for genetics and gender. She's wondering, how accurate are those results?
Those are very accurate. I mean, for gender, it's like 99%. And for, the trisomy family, 21, 18, 13, and 16, it's still in the range of about 99%, believe it or not. So for those specific chromosomal abnormalities, it's very reassuring.
That's amazing. That didn't even exist when I had my first child. Nobody was allowing us the 10-week blood test really yet. Yeah. And it's amazing, like how fast things are progressing.
Yeah, definitely.
Fertility Success Code is just saying hi from Canada. Hi to our Canadian friends. I'm not that far south actually from Canada these days. I'm in Idaho. Okay. So I'm only a couple hours away, but they don't want to let us in. All right. What causes chemical pregnancy losses? There's a two-part question here, because first I'd love to hear the, Dr. Sherry, OBGYN chemical pregnancy perspective. What do you know about them? There's a lot of people in our community that have had chemical loss after chemical loss. And because we're paying such close attention to our bodies, we know, right? We know the second that we're pregnant, and we know the second we're not.
Yeah, I mean, I think it's, sometimes we don't always know why you're pregnant for a week. 1 week. I mean, we know most miscarriages are often related to chromosomal abnormalities. So it's just, is this chemical loss just an early part of that? Was it something amiss hormonally? I mean, I'm sure there's some other theories to it, but it's not sort of like your true union of cells that create an early embryo that's unhealthy. And I'm curious what some of the newer theories are about chemical losses.
There's none. That's actually why I was asking you, because I thought, oh, maybe ACOG has published something more. I feel like we need research on this area. It's a big open question mark.
Yeah.
And yet most of us that have had one have had many.
Oh yeah, really?
Yeah.
How many?
Like it. Well, like more than 3. But it doesn't qualify as recurrent pregnancy loss workup, right? So it doesn't count in the RPL category. So we kind of are at this disservice medically, and that we have to advocate for getting workups that we intuitively think that we might want or need. And then and then we get this question a lot on the Fertility Answers app is, well, am I a low progesterone producer? And how would I know? And how would I get that timing right? Can I just add progesterone and then maybe I'll stay pregnant? Because if you do a frozen embryo transfer, you're on progesterone the entire time.
That's right.
So these things come up all the time. And I think the reality is we need more data, right?
Yeah.
So Soph is asking, and I think you answered it already, what causes a chemical miscarriage, especially if it's a PGT normal embryo, genetically tested embryo. And I think, if it was an early loss, there wouldn't be any tissue to even test.
Yeah, I mean, is that even considered a chemical pregnancy?
If she got a positive, and then, because, she would have checked her 2-week weight, maybe gotten a positive beta, and then the beta stopped rising.
So I mean, really early, yeah.
So I would, I don't know. So if maybe somebody's saying they can't hear us. I think other people are hearing us though. Jamenta, maybe jump out and then come back in, see if that works. Okay, K-May's asking, we only have 10 minutes left, everybody. So good questions coming in here. And I love, they're all so different. I love the variety of questions we get. Is it normal for breast fullness and tenderness to come and go early pregnancy? So she's 5 weeks now, but the kind of heavy soreness disappeared. And of course she's nervous because she had 6 miscarriages prior.
Wow.
It's a lot.
That's hard. And I totally understand, how, most women who've gone through that, it's like post-traumatic stress syndrome,
It is. Yes.
where, you're feeling the symptoms of pregnancy. Breast tenderness is certainly one of the beginning ones. And some women, believe it or not, the first week or two, their breasts are really sensitive and you can't even lay on them or have them touched. And then they get a little better. And that is not necessarily a bad sign.
Okay.
So don't worry.
That's the hardest part, right? Is that we're looking at everything. We want to sign good or bad. Like, I think we're just so hypersensitive to what's going on in our bodies at the time.
Yeah, it's hard. It's my heart is always really sort of more in the arms of someone that's going through infertility, because I know it's emotionally really challenging.
Yeah.
So I'm glad, Alice, that you have a great community. What you're doing with Answers, Fertility Answers is just so forward thinking for this group of people who have a place to go.
Yeah, we feel so honored that we get to do it. We love bringing all these accurate, personalized answers to everyone, because you just, even if you can email in a question to your doctor, I think a lot of people's instinct, Sherry, and I think you have a really unique relationship with your patients. I think a lot of people feel like they're being an extra burden on their doctor. And so we just like being this safe place where they can ask all the questions that they have.
Makes sense.
Fertility Success Code, thank you for that offer to bring hope to people, where statistics make you feel like you don't have any. We're going to start a new series on Sundays called Sunday Stories, where I interview success stories or actually just patients and hear their journey. So please DM me and we can set up a time to talk about that and get you involved. I would love any hopeful stories. That would be amazing. So yeah, Frenchie Jen is clarifying. So she's allowed to do up to 6 IUI, but they basically told her after 4, the next 2 likely won't work because it actually starts decreasing the chances. And it's through Kaiser Fertility, not a private fertility clinic. So I wonder if your IUIs are being coupled with Clomid, because that is true if you're on Clomid, because it thins the lining of the uterus. So usually, like, if you aren't successful by like that 4th time, we do see a decline in the percent success. So maybe clarify that for us. Sarah had an ultrasound yesterday and her eggs are really good. That is great news. Love that. Ash has a very healthy AMH level, 31, AMH of 4.6.
Wow, that's awesome.
Perfect.
Yeah,
yes.
Above 2 is really good. And I had also heard, though, Alice, and I don't know what you've heard about the AMH and how they're not using it as much anymore to predict ovarian reserve. And I know your finger's on the pulse.
We did our study measuring AMH through hair. And what we found is that measuring it through hair, where you're getting a 30-day window, as opposed to just a snapshot in time from blood, is more correlative to antral follicle count.
Wow.
Than blood. Yeah. So I think I don't think we have implemented the best clinical use case necessarily. And we need to get technologies like that, out there. I think that the hardest thing too about AMH is that it tells you nothing about your quality.
Mm-hmm.
Right. So I think that there's also a little bit of a false sense of hope if you have a really high level, and then also a really devastating consequence if it's low, where people feel like panic. I have to hurry up. And yet we see people have success with, below 1, usually through IVF. And we see people, who have really high levels of AMH that get good eggs out closer to 40 if they have PCOS, so it's a little bit all over the map, but it is still routinely used in the IVF setting. It absolutely is. This is great. Philip is asking, what is the number 1 vitamin that can help increase sperm motility?
I don't know what the latest is. I mean,
it's a combination, really.
Yeah,
it's gotta be like all antioxidants,
maybe
right?
Your recommendations, because I'm not doing that anymore, Alice. No more of the supplements for me. So
okay.
But you probably have some good recommendations.
Well, it's really about the antioxidants in general that we see, Philip, because you have a 3.5 month sperm washout. you want to focus on antioxidants that can help your body clear itself of toxins, everyday toxins, things that might get in the way of your sperm production. And you want to target that stem cell level. So I would just say, eat a lot of blueberries. There are male infertility vitamins or just male fertility prenatals. There's lots of options on Amazon for that. Okay, H. Blanca is asking, good to mature your eggs. Doctor says it's healthy, but they just don't mature. That sounds like she needs an IVF doctor though, if she can't get the follicles to grow.
Yeah.
Okay. This is great. All right. Let's see. Does a higher than the minimum required lining number required before transfer correlate with a higher implantation success rate? I read that fast because I'm confused by the question. Okay. So what I'm thinking, Philip, you're asking is if the lining is higher than the target lining, will that translate into a higher implantation success rate, which probably is going to be a Serena question on Monday? Maybe. Yeah, I think so. So Philip, that's a great question to either ask on the app. I will say this though, that Serena just last night on our show together said pregnancies can happen in a tube that has no lining, or even in the abdomen that has no lining. So they want to create the like most inviting environment for implantation to happen, but kind of on both ends of the spectrum, like pregnancies can happen in very weird places. And so they try to not, get too overly concerned if it's too low versus push too hard and make it too thick, because too thick can have a negative impact. So they really do try to get it into this kind of window. Yeah, Sarah, I'm so sorry. Her baby stopped growing at 6 weeks. So yeah, that's really hard. And we do, want to make sure that for all of those who have dealt with a loss, we have reproductive psychologists in our app. We have a wonderful emotional support program called Organic Conceptions that we work with that helps kind of take you through every process, including all the grief associated alongside the infertility journey. So we have wonderful support tools for you. Lauren, I love that support. Just, she's looked at every symptom too after experiencing a loss. And as hard as it is, we have to try to distract ourselves from worry. We like meditation. What are some of your favorite things, especially after this pandemic year? Sherry, I mean, you're frontline, you're a healthcare worker. And what are some of the ways that you cope with worry every day?
Well, I love music. I'm a 70s gal with music. I put on Jackson Brown's my go-to for just relaxing.
I love Jackson Brown.
And I'll just try to work out a little bit, even if it's walking on the treadmill. I just try to do something that I don't have to think about anything, but just myself.
Yeah. I love that. That's great. I know for me too, I definitely notice I have to have a sweat in the morning. I have to get on the Peloton to get those endorphins going. It definitely helps manage the worry wart in me for sure. Yeah. Red Cruz is saying that she heard zinc for motility. So we do have a genetic kit at fertilitygenetics.co that does help kind of break down some of the ways that men can help improve their motility if they are genetically set up for any kind of male infertility issues. So zinc, as our PhDs explained it to me, it's more to do with semen quality, not which can impact their ability to swim. So it's not so much the motility directly, it's more the quality of the fluid part, not the actual sperm part. So these are all great questions. Sherry, I hope you enjoyed it. Let me just double check the question thing.
Fun. Yeah,
okay,
thanks
great.
for having me. Let's do it again.
Let's do it again. So every other Tuesday, we're going to do this at same time. Bring all these awesome questions. Nothing is off the table. When it's outside of Dr. Sherry's practice, she'll punt it to, an IVF practice. But I love these questions. Some of these have never come up on another Instagram Live before. Fantastic. So thank you all for joining us. This will be saved on IGTV. Do us a favor if you have time, give us a subscription on our YouTube channel as well. These little steps help us maintain a free environment for you. And that can be found at youtube.com/fertilityanswers. And we will see you next week. Next week, I have 3 Instagram lives. So 3 special guests happening in 1 week.
Wow.
Sherry, I love
Busy.
you. It's so good
Love
to
you.
see you. Thank
Thanks
you.
for having me.
Thank you so
Bye.
much.